have a talk by Dr. Rakhi. She is going to talk on Miltefosine related keratitis, clinical characteristics.
Very good morning to everyone. I'll be speaking on Miltefosine related keratitis, clinical characteristics and management. I have no financial interest in the subject matter. Not moving, slides are not moving. So I have no financial interest in the subject matter. Miltefosine is a drug that is originally developed as an anti-malignant drug, and it has been recommended by WHO to treat all types of leishmaniasis since 2002. And since then, it is the first and is still the only oral drug that can be used to treat Kala-Azar and its sequelae, that is dermal leishmaniasis. Kala-Azar, as we all know, is caused by Leishmania donovani, and in 10 to 20% of apparent successful cured patients, they develop post-Kala-Azar dermal leishmaniasis. That is a potential source of Leishmania infection, and it is characterized by skin rashes. And its prevalence in Bihar is ranging from 4.4 to 7.8 per 10,000 people. So the recommended dose of miltefosine for PKDL is 100 milligrams per day for 84 days, that is 3 months, with some adverse reactions like mild gastrointestinal symptoms. However, there are some recent reports highlighting the severe corneal complications in patients taking miltefosine. These reports have lacked information about the clinical impression that is related to keratitis, and they reported the varies presentation of this keratitis from Murren's ulcer to scleritis. And there is little is known about its clinical course and management. So in this paper, we discuss the diagnostic clinical features, progression, and management of miltefosine related keratitis. And this was a retrospective study conducted from April 2018 to December 2021, including 6 PKDL patients receiving miltefosine, and a study was approved from IEC and written informed consent was obtained from all the patients. The evaluation included complete medical history, focusing mainly on the drugs used to treat the Kala-Azar and dermal leishmaniasis, and documentation of doses and duration of treatment, and the onset of keratitis after initiation was noted. We also performed the casualty assessment of adverse drug reaction to miltefosine by WHO UMC criteria. So we walked up all the patient for keratitis, including the size, shape, location, extent, and the present and absence of a hypopyon or epithelial defect, including corneal sensation. And laboratory evaluation included the smear examination and culture of corneal specimen, PCR, to rule out the Leishmania donovani in the corneal specimens. RK39, it is a rapid serodiagnostic test to confirm the PKDL, and a skin biopsy to rule out the LD bodies. So results of 6 patients. Case 1 was bilateral keratitis. He was taking miltefosine treatment for 48 days, and he continued taking this medication for another 17 days after the appearance of oculocys. So at the day of presentation, he had full thickness paralimbal ring-shaped infiltrates with hypopyon. And since it was a first case, we didn't start any steroid in this case, and we waited for the microbiological examination results. And within 2 days, this ulcer progressed and involved the corneal central cornea, as well as resulted into corneal thickness, for which patient required the penetrating keratoplasty in the right eye. And when the results came negative for any microbial organism, we started oral and topical steroid, and left eye resolved with this with 6/12 vision at the end of 5 months. Case 2 was also bilateral keratitis, and he was taking miltefosine for 35 days, and he continued taking this drug for another 20 days after appearance of symptoms and signs. And this was a very classical appearance of the signs. There was ring ulcer, paralimbal infiltrate rapidly involving the center as well as circumferential cornea, and for which he required PK in the right eye, and left eye responded very well to topical and oral steroid and resulted in 6/9 vision at the end of 4.5 months. Next 4 cases of our 6 cases were unilateral keratitis, and they all were taking miltefosine from 38 days to 65 days. One thing was common in all the patients, that they stopped taking miltefosine as they feel the ocular signs and symptoms. So and all these cases responded very well to topical steroid only, and they recovered their full vision in the span of 3 months. So in results, ocular signs and ocular symptoms were pain, watering, photophobia. Keratitis was very consistent in all the patients, ring-shaped, full thickness, paralimbal infiltrate. 2 cases had bilateral keratitis, 4 were unilateral. Laboratory results showed positive only for RK39 test and skin biopsy. Rest tests were the negative. The discontinuation of drug and initiation of corticosteroid therapy were the mainstay of treatment, and casualty assessment with WHO UMC criteria showed the probable association between ADR and miltefosine in all the patients. So we found a consistent pattern of keratitis and its course in all the patients who were receiving miltefosine, and on the basis of our results, we could divide these keratitis into 2 stages: early stage where the ring ulcer were present and there was intervening clear zone between limbus and the lesion, and an advanced case where the infiltrate extend both centripetally as well as circumferentially and resulted into ulcerative keratitis. So the mechanism of this keratitis is not very clear, but it has been hypothesized that this drug might be directly toxic to ocular tissues because of its long elimination life, that is 31 days, and development of keratitis could be an autoimmune response to the drug. So we suggested some management. One is stopping the drug immediately and excluding the infectious etiology, initiate the steroids as early as possible, and deferring the PK for all complicated cases. So this study indicates the prolonged use of miltefosine might cause keratitis that resembles infectious keratitis, and the early diagnosis with discontinuation of drug and initiation of corticosteroid therapy are the key to successful management. This study also emphasized that need to strengthen the pharmacovigilance program in endemic areas that monitors the serious complication, and patient receiving miltefosine should undergo periodic ocular examination by an ophthalmologist. These are the reference. Thank you.
So miltefosine has been used orally for acanthamoeba keratitis. So in those series, is there any report that the contralateral eye developed any toxicity or ulceration or anything like that? Like, how can you prove that that is the causal effect relationship? I mean,
so there are many studies, not many, but 3 or 4 studies which have documented the role of miltefosine in recalcitrant acanthamoeba keratitis. In these cases, other are usually not involved, but they have shown the worsening of symptoms and sign in the same eye after 1 week course, and in some of the study, they also added a steroid in the same time. So, and one thing is important in all those literature, that they have used this miltefosine maximally till 30 days or 35 days, not more than that. And we found the average duration of presenting this keratitis or infiltrate is around 5 weeks. So after 5 weeks, we should start monitoring these cases for appearance of these infiltrates.
And did you do a histopathology of the button samples of transplant?
I have not included that patient. He came late. That was the 7th patient, and we did histopathological examination just to see what is happening. And we found only the intense inflammatory reaction and no LD bodies, nothing very significant to the organism.
And how long this drug has been used, and are there any earlier data of similar type?
It is used for 28 days in visceral leishmaniasis, and in dermal leishmaniasis it is used for 84 days. So all these patients have already taken the drug, this drug for visceral leishmaniasis also, that is for Kala Azar, but they didn't develop this much of sign. And after continuing 5 or 6 weeks, they start developing this kind of symptoms. So it needs an intense monitoring while using this drug. And that is very important. Thank you, sir.
That was a very nice study, Dr. Rakhi. So do you think, Dr. Rakhi, do you think we should start steroid immediately, or we have to wait for culture report to come and then only start steroid? in such patients?
After seeing 6 patient or 7 patient, I would recommend that if the history is present there, like Miltefosine history is very strong and patient is giving you a history and you can see those tablets with them, then don't wait for long. Start topical and oral steroid depending upon the severity. Like I showed the 4 cases, they stop the drug immediately when they get symptoms. And as they came to us, we started topical steroid immediately. After taking just sample for the microbiological examination, and they responded very well without any residual scarring or this thing, and they get 6 vision within 3 months.
Any other systemic comorbidity other than leishmaniasis?
They had just dermal leishmaniasis, and for which we referred them back to the Kala Azar Center.
Other than
no,
leishmaniasis?
no, sir, nothing.